speakers therein. I'm Dr. Rohit, and I'll be taking over the session from Dr. Sushit now. To introduce Dr. Hans Grabe, as Professor said, he is a well-accomplished psychiatrist and a researcher. Dr. Hans Grabe will be addressing the intricate facets of the long-term consequences of traumatization, drawing from cutting-edge research in psychology and related fields. The presentation is poised to explore how traumatic experiences can imprint lasting effects on mental health, behavior, and overall well-being. By delving into recent findings, Dr. Hans Grabe will be navigating the nuances of resilience, coping mechanisms, and potential avenues for intervention in the aftermath of trauma. It promises to be an enlightening discourse, unveiling insights that contribute to a collective understanding of the enduring impact, traumatization, and the human side. Dr. Hans Grabe, over to you.
Hello?
Yeah, Dr. Hans Grabe, over to you.
So, can you hear me, Rohit?
Yes, I can hear you, Professor.
Okay. So you're finished with the introduction?
Yes, I did.
Okay, then I'm starting. Rohit, thanks a lot for the introduction. Thanks to Rainer for inviting me and to being so modest all the time. Concerning your own achievements, which are really great, in fact. I'm very happy to give the talk on the long-term consequences of traumatization, new findings. It's the third time in this round that I give the presentation on this topic, and I think I will share some already known slides with you, expecting that in the audience new members have been joining compared to last year. But I will also demonstrate a couple of new findings which are really intriguing and pretty new. So, yeah.
Can I just sorry, Hans. Can I ask you, did you take your language as German or English? Because when I see the captations, they sometimes make no sense. Now it works here, but make sure that if you take their language, that it's English. Yeah.
You mean the language for the PowerPoint or for what?
For the captations, so your captations don't make sense because you possibly have your captations so your language is possibly put to German.
Okay.
I do not know. You have to do it on your own. On your own.
Okay, that's.
I don't know, Daria. Do you know how that works?
Do I have to do it in the PowerPoint presentation?
I think, Daria, can you unmute? Daria, please. Daria Ahmed, can you just unmute and just help us?
There's no problem from my side. I can see the screen. And
no, but you possibly know he has. So it seems that the captations Hans has are trying to send it to German. So because I can see this Z, I can see some letters I would only see in German. So where is the language? I don't know.
This is the problem for all. There's nothing show from my side. I think you are opening your caption. There's a 3 dot above, and you can hide the caption because you are the main host.
Right. Okay. Can you? Okay, just let's go on then. If we can't, I just try to. Okay.
So yeah, because it's a quite conventional presentation. So yeah, this is the main building of our university in the city of Greifswald. It's a very old university, and in fact, it was established by the Swedish people that were conquering the northern part of Germany in the 16th century, which is quite interesting. And I will present a couple of data that we derived from our study of Pfalz and Pomerania study, the ship study that has been conducted in the northeastern part of Germany. Yeah, you can see Berlin. So maybe I will switch this down. So, oh, now it's indicating that the screen share has been interrupted. Is this true?
You're visible.
I'm visible. Okay, then I'm just continuing. Okay, you can see Mecklenburg-Vorpommern, the northern part of Germany, and here are the cities of Greifswald and Stralsund next to the island of Rügen, which is really very nice. Okay, here are the white chalk cliffs of Rügen. This is our scanner from the study of Pfalz and Pomerania. Since 15 years, we are investigating the whole body MRI scans from all participants of the study of Pfalz and Pomerania. And this is just an example of a conventional GWAS plot, indicating that we are doing a lot of omics data analyses, which is quite interesting. But today I'm not talking about all the omics and genetic stuff. We are following a multi-level systems approach, especially when we are talking about childhood trauma. Childhood trauma, of course, occurs in childhood. This is pretty clear. And this is also one of the main problems, that childhood trauma occurs very, very early in life, and that childhood trauma hits during a very sensitive period into the child's brain, because the child is developing, the child's brain is developing, all the neurons are being connected, and all the networks are doing all their learning driven by interactions and by the environment, by all the sensory input. And during this very, very sensible and vulnerable period, childhood trauma really disrupts and interferes with all these learning processes and all this stuff like memory consolidation and robust attachment and binding. So this is pretty harmful to many of the victims, and we are investigating in the adults, of course, a lot of genetic data, transcriptomic data, proteomic data, and we're doing MRI scanning. And in the end,
can I ask you, do you move the slides forward? Because I still see the study of Pfalz and Pomerania. Is this correct?
Oh, yes. No. I'm moving the slides forward. So, okay, maybe I will stop again, and I will try to share the presentation one more time. So now it should work again.
Yeah, if you go into presentation, yeah. Okay.
So, can you see my presentation now?
I can see Max Ernst, so.
Yeah, exactly. That's cool.
Okay, if you can.
I was talking about this slide, the childhood trauma slide, and all the different omics layers, the MRI, and the way that we try to connect all these different layers of information to make sense in a risk model approach to understand what is driving the onset and the maintenance of mental disorders. We all know that childhood maltreatment is pretty frequent. This is a study from The Lancet a couple of years ago. And already in this study, they came to the point to say that in the high income countries, 4 to 16% of all the children are physically abused, and 1 in 10 is neglected or psychologically abused, and that 5 to 10% of the girls and up to 5% of the boys are exposed to penetrative sexual abuse. And, these are figures that run throughout each country and throughout rural areas, urban areas. These are, I would not like to say these are constant drivers of human society, but everywhere you make research, you find those numbers. Also in our beautiful landscape, in a pretty rural area at the Baltic seaside, where we are doing the research, also in this area, we find pretty robust rates of childhood abuse. We know that childhood trauma is associated with a number of mental disorders. In the clinic, we see all day long patients suffering from all these various kinds of disorders who have been exposed to neglect, to emotional, physical, or sexual abuse. These are high rates, and it's without doubt that childhood trauma is a driving risk factor for all these disorders. That's pretty clear. But I would like to back up those clinical impressions by data that we are collecting and data that we are allowed to analyze. I would like to draw your attention to the German national cohort, to the NARCO study. The NARCO study is a very, very nice study. It has been started in 2014. There are a lot of study centers throughout Germany. It's supposed to collect a pretty representative sample of the German population in almost each federal state. And in the first wave, in the baseline wave, more than 200,000 people were enrolled in the study. And during the follow-up wave, which is running right now, 117,000 subjects have been enrolled until the end of September. Probably there will be a couple of additional enrollments. And yeah, it's a huge study. And the assessment protocol is really huge with different levels of assessment. We have a broad level, level 1, that everybody is receiving, who's participating, and then we have level 2. Level 2 is even a more intense way of phenotyping the subjects. About 40,000 subjects are participating into the level 2 examinations, which comprise a very broad neurocognitive test battery, also a whole body MRI protocol, and various other tests and interviews. So the 40,000 sample is really deeply phenotyped, and the rest is, I would say, still very robustly phenotyped. You can do a lot of research with the whole 200,000 subject sample. Last year, I was already able to present our first paper from the NARCO that was published in the World Journal of Biological Psychiatry. Back in that days, we had only the sample, the starting sample available after a quality control, roughly 76,000 subjects. And we were analyzing in this paper the so-called CTS items, the childhood trauma screener items. The childhood trauma screener has been derived from the childhood trauma questionnaire. The childhood trauma questionnaire has about 28 items, which is far too long for such an epidemiological study, because time is money, and the participants are requested to fill in numerous questionnaires, and each single item counts in terms of participation, in terms of missing values and stuff like this. So we try to reduce the 28 item questionnaire to 5 items that are representative of these 5 dimensions of physical neglect, emotional neglect, physical abuse, emotional abuse, and sexual abuse. And on the right side, you can see the prevalence in this sample of maltreated subjects. What's the definition of maltreatment? We say if you suffer, for example, from physical neglect to a very high degree. And the question was, for example, when I was growing up, I knew there was someone to take care of me and to protect me. And when the participants are indicating never or rarely, this is a severe rating score for this item, whereas sometimes, often, or very often is the positive rating. So everything was fine in their childhood in terms of physical neglect. So just when they are indicating never or rarely, we consider them to be physically neglected. And this goes through the other questions as well. Emotional neglect, for example, someone in my family helped me feel important or special. Physical abuse, I got hit so hard that I had to see a doctor or to go to the hospital, which is really a very high level. Emotional abuse, people in my family called me stupid, lazy, or ugly. Sexual abuse, someone tried to touch me in a sexual way or made me touch him. So these are the items, the wording of the items. You can see for sexual abuse, the definition is a little bit broader. So when the participants are indicating this occurred rarely, we already consider this as being positive for this item. Whereas, for example, emotional abuse, you at least need the rating of sometimes, the scoring of sometimes, before we say this subdimension is considered to be fulfilled. So here are the prevalences. You see they are not too high because of our strict definition, but this is something that I would consider to be the core of maltreatment. And sometimes the subjects fulfill a couple of these dimensions. It's not only a single dimension, but they are interrelated, of course. And last year, I already showed that indicated in black, the people with childhood abuse experienced higher scores of depression in terms of PHQ-9 ratings. This is abuse, this is neglect, this is any kind of treatment. And GAD-7, this is general anxiety scores. Even there you can see it's a clear effect of childhood trauma or maltreatment. And also in the PHQ stress scale, you can see that those people who indicated childhood trauma many decades before still are suffering in mean from much higher values in terms of recent stress experiences. So, and now I would like to move to another paper from the NACO. This paper has been accepted for publication in the German Ärzteblatt, Deutsche Ärzteblatt. Currently it's in press. The title is Childhood Maltreatment as Risk Factor for Somatic and Psychiatric Disorders. Now just to move this. During adulthood in a narco health study. Here we can see that roughly 156,000 subjects are enrolled in all these different disorders. So we were investigating in this study cancer, myocardial infarction, stroke, diabetes, COPD, anxiety, and depression. I just mentioned here the German wording because in the following figures, I'm sticking to the German word because I was not able to change the figure because it just had the PDF. So it's cancer is Krebs, and stroke is Schlaganfall, and anxiety is Angst. Probably you know it from the German Angst, which became internationally very famous. German Angst. So, okay, what did we do? You can see here on the y-axis the odds ratio for the likelihood of the occurrence of all these disorders. The first one is cancer, the second is myocardial infarction and stroke, diabetes, so COPD, anxiety and depression. And in gray, you can see that these are the subjects who have indicated that they have no childhood traumatization or just a mild form, which we consider as none, or they are indicating a moderate to severe childhood abuse, which is indicated in the orange-red dot. So I will go through the different points. In cancer, you can see a statistically significant increase in the incidence of cancer in the people who are indicating a childhood trauma event. Myocardial infarction, you see there is a connection of the confidence intervals, but nevertheless there is some kind of increase in the rate of myocardial infarction. Overall age groups. Stroke, the third one, is very clearly elevated in the subjects with childhood trauma. Diabetes, it's also elevated. In COPD, it's even more elevated. And as we all can imagine, that the association to the mental disorder dimensions like anxiety and depression is even much more higher, with odds ratios between 2 and 2.5. So the rates are doubling in the general population. And I think it's important to mention that many people who are suffering or who have been suffering from childhood trauma in their childhood or youth, they are able to cope with it. But when the people becomes really under pressure or come under pressure, and if really life burden is kicking in, then their resilience to other stressful life events can be diminished. And you know, this is an interaction with a lot of stress factors that can eventually lead to not only a mental disease but also to physical disease. But here in this figure, you just see the straight association of all subjects with childhood trauma without any other risk factors. So it's just the base rate of association. I think the next slide is pretty interesting. So it's the same like this, but we were stratifying the age ranges. And now the picture becomes more interesting. I will walk you through this slide. We are starting with cancer on the left side here. Again, all the subjects without childhood trauma are being set to 1 as it's a reference group. And in orange or red, you can see the subjects with childhood trauma. And now we have the different age groups. In circle, this is the age group under 40. With a triangle, this is a group between 40 and 60. And the last one is the group above 60. And now a very interesting picture emerges, because you can see that the younger age groups have a much higher odds ratio for the given physical and mental diseases when they have been exposed to childhood trauma. And now the associations become, let's say, more relevant, even more clinically relevant, because an odds ratio of 1.5 is a 50% increase in risk. So it's much more prominent. If I compare this to the previous slide, you can see the cancer risk. Yeah, it was, I don't know, 1.2 probably, or 1.15. So not that compelling, but if you really look at the age stratification, you see that the younger people have a clearly elevated risk for cancer when they've been exposed to childhood trauma. Also, the same story holds for myocardial infarction, 50% increase. In the age group now between 40 and 60, there were literally no cases with myocardial infarction below 40. Also for stroke, you see the increase. Also here, no cases below the age of 40. Diabetes, the same story. COPD, you see the elevated scores. There it's not that clear, but again, the youngest group is leading. And when it comes to the mental syndromes, anxiety and depression, you can see that the youngest groups have far more the highest odds ratios for the given disorder when they have been exposed to childhood trauma. So one conclusion from this slide would be that childhood trauma is really affecting the onset of the disorder, of the physical or the mental disorder. There's a shift to earlier ages of onset, which, to be honest, which we can't prove in this analysis because we simply stratified the age groups of the subjects. We were not stratifying the age of onsets because these data were not available so far. But it's pretty clear that with stratifying the age groups of the subjects, we also stratify to some extent the age of onset groups. So I think this is pretty interesting, and this becomes really clinically relevant because we see in everyday clinical practice that severely affected people from childhood trauma, they do suffer from multiple physical disorders. And here you can see that they do occur not only in numbers throughout the life, but also earlier in life. Okay, and now I jump back to the study for Pomerania. Our study at Greifswald University. Here we were conducting interviews, clinical interviews for the assessment of depressive disorders. And you can see the lifetime prevalence rates were, of course, increased in subjects that have been exposed to childhood neglect and especially to abuse. The interesting point here is that we can see that emotional abuse is really the driving force behind lifetime major depressive disorders. It's an odds ratio of 4, so a massive odds ratio compared to physical abuse, sexual abuse, or emotional neglect, which is still an odds ratio of 2, but the other one is 4. So emotional abuse is really a high risk factor for depressive disorders. This slide I have been presenting last year already, but I think it's an important slide because everyone can conceive the association between childhood trauma and depressive disorders. A lot of interactional stuff is going on, a lot of negative emotional binding, a lot of self-consciousness, and all the storyline goes along, which is clinically really reasonable and conceivable. But also in psychosis, it has become pretty clear that a lot of factors in childhood and adolescent are contributing to the risk of psychosis. And yeah, this nice figure really shows the more or less common concepts that we have first wave hits in the pathogenesis of psychosis, and we have second wave hits. So the first wave hits are very, very early risk factors that are occurring even before birth or around birth. You can have obstetric complications, you can have prenatal infections, you can have a couple of traumatic events in your childhood, and later on you get a second wave fit that is really destabilizing your vulnerable neural networks. And if all these factors are acting together in probably genetically predisposed subjects, you will experience something like the first episode. And you can see here all the risk factors that have been identified, like the childhood trauma here, and low childhood or adolescence functioning, tobacco use, male gender, single status, unemployment, affective comorbidities, physical inactivity, social deficits, ethnic minorities, and all the neurobiological risk factors that we know nowadays. So also here, the life environment plays a decisive role in the onset of psychosis. Yeah, this is a slide that I like very much, because childhood trauma really kicks off a whole range of problems. First of all, mental problems that we've already seen. Then we have physical problems in terms of activation or dysregulation of the HPA axis, often associated with chronic inflammation and metabolic problems. And then we have behavioral risk factors that we already heard about: smoking, drug use, alcohol use, physical activity, more or less inactivity, malnutrition, and all this adds up to the risk for cardiovascular disease or for diabetes. So this is a whole bunch of interacting risk factors, and there's a lot of data for this highly pathogenic environment and all these pathogenic interactions that are taking place in our patients. Yeah, so back and forth, highly interactive. So yeah, and just to mention the association between childhood trauma and some of the autoimmune diseases like rheumatoid arthritis. It's interesting because we have to acknowledge that childhood trauma obviously leads to some very early dysregulation of the immune system. So the distinction between self tissue and tissue from bacteria from outside the body is not working properly. So there is a higher risk for autoimmune disease in subjects with childhood trauma. You can say the increase of odds ratio for all these facets of childhood trauma in a patient with rheumatoid arthritis. Pretty robust odds ratios. And the same occurs when we are talking about multiple sclerosis. Just have to switch this one. You see case control study here, again, for emotional abuse and for sexual abuse and emotional neglect. You see pretty strong effect sizes, which are highly significant. So also in a brain-related disease, autoimmune disease, you have a higher risk in subjects that were exposed or have been exposed to childhood trauma. And this study, the ACE study, it's a very famous study. I love to show this slide for everybody who's new into the field. Should really go to PubMed and visit the ACE study. Many publications have been written based on this database from an health insurance company from California. Also dealing, you can see, with autoimmune disease, with ischemic heart disease, with pulmonary disease, and liver disease. It's really very interesting. And this is a paper that we were publishing 2 years ago. It's a paper that is really focusing on lung function. The good point about this paper is that we, of course, used questionnaires, but we also used objective measures of lung function. And you can see that we had 350 subjects with childhood maltreatment positive and more than 1,000 without childhood trauma. And these are the results from the questionnaires or from the interview. What you can see is that the patients with childhood trauma had a significantly higher intake of medication for lung function. They were reporting much higher rates of wheeze without having a cold, which is highly significant. They also were suffering to a higher extent from asthma and chronic bronchitis, but that was not statistically significant. And asthma attacks were much more prevalent. You can see an odds ratio of 4, which is quite nice. So the subjective experience was much worse in the people of childhood maltreatment. And when we used our objective measures of lung function, the picture changed. Let me just briefly describe what we did. We were measuring the FEV1. So the FEV1, this is the forced expiratory volume that you can expire in 1 second. So it's a lab testing. The FVC, this is the forced vital capacity. So how large is your volume that you can really breathe in and breathe out if you work hard on this breathing operation. And you can see that all tests are non-significant. There are some slight differences, but they were not statistically significant in this sample, which is not really a small sample. So these are only minor differences. And compared to the results of the previous slides, one has to conclude that probably the patient with childhood trauma, they were receiving more medication. Maybe they had a very, very good treatment, and their objective parameters were not really different from those without childhood trauma, which can be really a very, very good result of all the medical treatment that is taking place in Germany. But in the end, it remains that, we're just going back, that the subjective ratings were much worse. So the wheeze without having cold, the rate of asthma, chronic bronchitis, the asthma attacks, everything was rated much worse by the participants. Disrespect the objective measures. So, and I think this is a point that maybe subjects with childhood trauma are more sensitive to physical stress, that they are more prone to negative subjective experiences, and that they are in fact suffering more from the same disease, from the same underlying disease, because of their vulnerability. Okay, this is a result slide from the ACE study comparing the degree of childhood trauma to the rate of cardiovascular disease in the ACE study. You can see here, this is the ACE score. With increasing scores, you have much higher ratings of childhood trauma. And the endpoint was ischemic heart disease. And this is a logistic regression analysis. And you can see that with increasing ACE scores, you have an increase in odds ratio for ischemic heart disease. which is increasing from 1.1 with one childhood trauma symptom in the ACE score up to 3.6 when you are at maximum with your childhood trauma rating. And when the authors were using different models, the odds ratio decreased a little bit. The different models are referring to different sets of covariates of different sets of confounders. So when we take a look at the fourth model, this is a model where they were really adjusting for everything, and they were adjusting for age, sex, race, education, and then they were adding smoking, physical inactivity, body mass index, diabetes, hypertension, and then they were adding anger and depressed affect. They were including all those covariates into the last model, and I assume that some of those confounders were in fact mediators, but okay, let's take it like it is. There was still a 2.3 odds ratio, so a 130% increase in ischemic heart disease, irrespective of all those confounders, which is a strong result and which really matches very nicely into the other data that are already presented. There are strong interactive risk factors and childhood trauma, also because it is occurring that early in life, is a driving force behind a lot of physiological and behavioral risk factors. Okay, we just have a couple of minutes to go. I will briefly refer to some of our results in terms of the MRI research and brain structure. I pointed out before that the developing brain is pretty vulnerable because, of course, in the prenatal phase and in the childhood phase, in the adolescence, the brain growth is performing really high tasks. The brain is connecting all the neurons, the networks, and is really making up a picture of the world, and everything is developing, the personality, the language skills, the social skills, everything. And stress might be very, very harmful to this process. And there's a study where the authors tried to figure out in which phase stress is most harmful, and yeah, they define also stress on the HPA axis, where you get problems with the growth of hippocampus and the neuroplasticity of the hippocampus, which is really affected in the postnatal stress phase, or in adolescence, you have problems with the maturation of the frontal cortex. And yes, in adulthood, you have problems with the emotion regulation and the amygdala. And very early on, you get problems with neurodegeneration or with dysfunctions because all your networks are being exposed to too much stress. So it's something that is phase dependent, but in the end, you can say stress is not really good, at least if the stress level exceeds a certain threshold. Okay, this is a very, very well-known study, which has been replicated many, many times. You can see that there's a strong, clear correlation between the exposure to childhood trauma and the gray matter volume of the hippocampus. You see that it's, of course, it's a negative association. The more childhood trauma the subjects have been experienced, the smaller their gray matter volume is in the hippocampal area. We made a study based on CHIP with 1,500 subjects. And I think this is a very, at first sight, it's a very, very simple figure. Yes, it is, but it's interesting. It's really interesting because we were analyzing the interaction between abuse and no abuse with the severity of depressive disorders. Because, like I mentioned before, many people from the general population who have been exposed to childhood trauma learn to cope pretty well with the trauma or have a lot of stabilizing environmental factors like grandparents or good peer groups and stuff like this. So they are able to outweigh the stressful childhood experiences. And they are performing pretty well throughout their lives. They have developed psychosocial coping strategies and probably also neural coping strategies. And the people who are developing depression later in life, they have probably not been able to compensate for the childhood trauma because they are developing a major depressive disorder. They are really suffering and they are not performing that well. And so we analyzed the interaction because this makes a lot of sense. So we take a look at the subjects with no depression. And if you look at the subjects with no depression, and here we have the whole brain cortical thickness. It's an overall measurement of cortical thickness of brain integrity. You see that the people with childhood trauma, with abuse, have a higher mean cortical thickness compared to the non-depressed, non-abused subjects. So this is interesting because this could probably indicate that there was something going on like compensatory mechanisms, really in neurobiological strengthening of the brain to really be able to cope with the childhood trauma. Okay, this is an interpretation, but probably it works. And we were also analyzing all these effects in various brain areas separately, of course. And if you go to the group of mild depression, their both groups are pretty overlapping. And when we enter the stage of severe, oh, is it possible to mute Imran? Imran, can you mute your mic? Okay, now it's silent. Imran, is it possible for you, or can I mute your mic?
I can do that. I think I should do that.
Okay,
Give me a second.
great. So, and when we enter into the group of severe, moderate to severe depression, then we see something that we're expecting that the people with childhood abuse and moderate to severe depressive disorders had the lowest cortical thickness in mean compared to the subjects with no abuse. So this is pretty straight line here. So the message is that the people with abuse are not performing bad or worse in every condition, but when depression enters so-called the game of childhood abuse, when childhood abuse is that severe that coping is not sufficient to keep depression away, then we see a neurobiological correlate in terms of lower cortical thickness. In the other end of the spectrum, people with childhood abuse without depression obviously are performing pretty well in their life nowadays, and probably they have developed coping mechanisms, psychosocial coping mechanisms that have a correlate in cortical thickness. So this, of course, is a lot of interpretation, but behind the data set, like I mentioned, 1,000 500 subjects, not too bad. And the confidence intervals are acceptable, they're not overlapping. Okay. So, and you can see here the brain areas indicated in red that are really affected from this interaction. So it's not throughout the brain, but these areas are really driving the mean cortical effect that I've been showing in the figure before. Of course, they are important brain areas for emotional and affective regulation. So, and now I come to my last slide. I will just show data from the SHIP study where we were comparing 4 groups of subjects. These are subjects with childhood trauma, with low resilience or with high resilience, distinct subjects, or subjects without childhood trauma with low resilience or high resilience. You see that, of course, there are more subjects without childhood trauma. This is clear if you compare the overall numbers. And for resilience, we made median split of resilience. The score, we just took the score and separate for males and females and made the median split. So you can see that it's kind of weighted here. And I will just go on. So this is the rate of lifetime depressive disorder in the given group. So the group without childhood trauma and with high resilience had the, of course, lowest rate of lifetime major depression, but still 11%. So let's go further. This is the opposite spectrum. This is the group with childhood trauma, moderate to severe, and with low resilience measured by RS25, the resilience scale. So the depression rate, lifetime depression rate, is peaking up to 30%. And the next one, childhood trauma, positive. But high resilience, you see that they are doing quite well. This is what I just mentioned in the study before, in the brain imaging study. There are people with childhood trauma who are coping pretty well. And the rate 13.8 compared to 11.2, that's not a too big difference. So they are really performing both very, very well. And now the last group, childhood without trauma and low resilience. Yeah, so you can imagine the depression rate is probably lower than 30%, but it's not that low. It's 18.4%. Yeah. So the take-home message: there's strong protection by resilience, and this also makes the point that it's probably important to, if you're really interested in understanding the long-term consequences of childhood trauma, it's probably important to separate these groups, to separate the group that is really suffering also from nowadays low resilience and maybe high rates of depressive disorders, compared to the people with childhood trauma but with high resilience and low rates of depressive disorders. So there are 2 very, very different trajectories. I would bet that also in terms of all the physical diseases, we would have very, very different prevalence rates between both groups. But that's just an hypothesis, and we are trying to get more data on this, of course. So my summary: childhood abuse is prevalent, more than 10% in the general population. Childhood neglect is even more prevalent, more than 20%. There's a high impact of childhood maltreatment on the etiology of different mental disorders, as well as the physical health, especially in younger people, that we learned from the NARCO study. there might, especially in severely affected patients, there might be a strong alteration of psychosocial and psychobiological development. And yeah, the question is on the transgenerational trauma transmission, something that can probably take place in terms of the psychosocial behavior, the interaction, or the model learning from the parents. But there are also findings that point to altered microRNA signatures in people with childhood abuse. We have also published a couple of papers on altered microRNA patterns in whole blood in subjects from the general population that were suffering from childhood trauma. And it's conceivable that these signatures probably affect the second generation. And it's known that sperm are a carrier of a lot of microRNA information to the egg of the woman. So this could be a biological way to transport environmental information from one generation to the other via biological ways and molecules. So thanks a lot for your attention. I was very happy that I could be here with you today. So questions?
May I just, when you look at these brain studies, what's cause and consequence? Because some people, let's say kids who have less education or whatever, have ADHD or autism or alcohol, they behave a little bit, if you have whatever less or ADHD or ASD, wouldn't that cause more trauma as a consequence? So what's cause and consequence? So if you have behavioral problems because you have brain, poor memory or brain disorders or anything, so what's the cause and consequence there? How can you sort this out? And the other one is if you take poverty, or let's say poverty and inequality away, how would that look like?
Yes, I'm totally agreeing with you that sometimes the victim is driving the abuse by himself or herself as well. We can't rule out this way of interaction. Yeah, the victim is not always the passive one, and especially when people have been victimized, they change their behavior and they become probably exposed to new forms of traumatization. They are engaging in fights. They are engaging in probably emotional abuse because they are misbehaving in school and stuff like this. So I really think that the assessment of childhood trauma is something like a surrogate parameter for a dysfunctional environment, a dysfunctional interactive world. And when we are talking about genetics, we know that at least in conventional families, the children are the product of their parents. And the parents are carrying 50% of the child's DNA, and so and vice versa. So it's a mixture, definitely of biological factors and behavioral factors, and especially, when we're talking about autism, I think there might be parents that are really very far away from autism, but they are being really traumatized by their autistic child because it's misbehaving in a very strong way. It has obsessive compulsive rituals. It's very sensitive to any kind of environmental change or behavioral change that's going on in the family. So it can be very, very stressful. On the other hand, when we are talking about ADHD, it's something where you can really feel that the whole family is affected. Often we see the parents, they come in our treatment, they get psychotherapy, and then they are reporting from their children, and they are reporting a lot of school problems, and they're reporting behavioral problems. And in the end, when they were children, our nowadays patients and the parents, they were the same. So there also might be a genetic component that is jumping from generation to generation, and we just measure something like the behavioral outbursts of all the genetic complications. Yeah.
Right. Okay. Are there any other questions at the moment?
I'll ask one question, quick question.
Yeah, sure.
So thanks for the presentation. I just wanted to clarify. As I looked at your last slide with the data, it seems to me that it's the resilience that really differentiates whether you've been sexually abused or not in terms of subsequent depression. If I looked at those percentages, they were, I don't know if there's even a statistical difference. But it seems to me that the resilience more than the abuse seems to predict whether there's subsequent depression. Is that a simplistic reading of the situation, or is that reasonable?
You know, when we take a look at exactly these data, your interpretation is right. But these were subjects from the general population. And if you go into clinical departments, you see a lot of victims who only have a very, very small degree of resilience left because their traumatization was very severe. So even if you have high scores on the childhood trauma questionnaires, it's general population, and you know, if you have reached the maximum of the scale, you still in real life can experience much more traumatization than the maximum score of the score. You know, there's no end to drama and to traumatization.
Right.
And in the clinical practice, we are seeing people who have been traumatized for years and with very, very different traitors and different methods, means. And so the scale is not really differentiating in this high-end area of abuse. Not really.
Okay, fair enough. Thank you.
Yeah.
Okay. I have to say thank you to Hans. Thanks a lot. Yeah, so I think it was a great, I don't know, just